Now we're going to talk about the ischemic heart diseases, how we're going to manage a patient within the acute setting, okay? So number one, we have stable angina and we have our acute coronary syndromes, okay? Now, regardless of how bad and how severe our ischemic heart disease is going to be, we're going to have the same exact symptoms within all of the ischemic heart diseases, okay? The symptoms, like we said before, of course, are going to be, the patients are going to have chest pain. This chest pain, again, is going to be a feeling that something is going to be very pressure on their chest. It feels like an elephant is sitting on their chest. This pain is going to be very dull. They're not able to basically pinpoint the pain, and as well it can go in and radiate to the arm and to the shoulders. Okay, that typically is what we see within all of the ischemic heart diseases. In addition, we're also going to have the sympathetic nervous system stimulation, so we can have tachycardia, we can have tachypnea, and of course we can have diaphoresis. Okay. And of course, depending on, especially the later stage of myocardial infarction, we could also have, dyspnea, acute pulmonary edema, and etc. Okay. Now, first of all, the reason why we're getting all these symptoms, of course, like we mentioned before, what happens is because the coronary artery is going to be obstructed, we're going to have less oxygen going into the heart and perfusing the heart. So typically, if a person starts to go and do exercise where he's increasing his cardiac work, anytime we're increasing our cardiac work, for example, he's exercising, or let's say he's in the cold, or let's say he just ate a very heavy meal, or let's say he got very emotional, whatever it is, if we're going to increase our cardiac work, what's going to happen is, because we're going to have decreased oxygen supply, then the cells are going to start to get hungry, and we're going to develop ischemia. And when we develop ischemia to our myocardial cells, we're going to start getting these ischemic chest pain. Okay. Now, the treatment for stable angina, of course, is, well, if we're going to be increasing the cardiac work, which is causing the patients to get sort of chest pain. So that means if we go and we tell the patient to stop and just to rest, just to lie down and relax and rest, what we're going to happen is we're going to be decreasing the cardiac work, which means that we're going to decreasing the amount of oxygen we have to supply to the myocardial tissue, which means that the chest pain and the ischemia is going to go away. Okay. In addition, we could also give the patient nitrates. Okay, nitrates basically are vasodilators. Okay. Now, a lot of people think that nitrates actually dilate the coronary arteries, but that's not really true. Nitrates might very significantly dilate the coronary arteries. You have to understand, because there's an obstruction, it doesn't really make a difference. Okay. But really, what nitrates and really the way they work is they basically decrease the venous return. Okay, and when we decrease venous return, what's going to happen is we're going to be decreasing the end-diastolic volume, which means we decrease the stroke volume, which means we decrease what is known as the volume load, which is basically fully proportionate to the cardiac work. Okay, cardiac work is fully proportionate to the volume load as well as the pressure load. Okay, so if we decrease the venous return, we're decreasing volume load, which means cardiac work, which means we're decreasing the amount of oxygen a person's heart needs to have. Okay, and that's why nitrates basically relieve the chest pain, because it decreases the amount of oxygen the heart needs to use. Okay, and typically stable angina usually lasts for about 1 to 30 minutes. Okay, of course, in this time, obviously, we'll be giving the patient oxygen, we'll be telling the patient to rest, and we're telling the patient to give, and we're going to give the patient's nitroglycerin. Okay. Now, very important thing about nitrates: you can only give nitrates, and before you give nitrates, you have to make sure your patient, and these are the contraindications. Number one, he has to make sure that his systolic blood pressure is going to be at least over 120. In addition, you want to make sure the patient isn't on any other vasodilators. For example, he's not on Viagra. Okay, because a person is on, let's say, already a vasodilator, and we're giving him another vasodilator, then we could go and cause very severe hypotension. Okay, and of course, very severe hypotension having with angina is just going to make it worse. Okay, so if the patient, let's say, you're let's say a paramedic, you're a doctor, and you arrive to the scene, the patient's having very severe chest pain that seems like it's some type of ischemic chest pain. You go, of course, you give the oxygen, you give the nitrates, and tell them to rest. And normally, if it's stable angina, what's going to happen is the patient, at least with 1 to 30 minutes, he's going to start getting better. Really 25 minutes, he start getting better. If however, he's not getting better despite giving nitrates and resting, then we go and we progress to what is known as acute coronary syndrome. Okay. Now, acute coronary syndrome can mean that the patient either has, number one, stable angina, or he could have a myocardial infarction. Now, myocardial infarction is basically split into two different groups. we have what is known as a non-ST segment elevation myocardial infarction, also known as an STEMI, and we have a ST segment elevation myocardial infarction, also known as STEMI. Okay, in order to understand this, we have to understand a little thing about our myocardial tissue. Okay, so normally our myocardial tissue is made up of 3 layers. Okay, we have the submyocardium, we have the middle myocardium, and we have the outer myocardium. Okay, now normally what happens is blood supply is going to be the most into the outer myocardium, then the middle, and lastly is going to be the sub. Okay, the sub is going to have the least amount of blood supply. So if a person is going to have an obstruction to his coronary artery, the first of course the layers that are going to be affected is going to be the submyocardium. Okay, and this is exactly what a non-ST segment elevation is. This is basically the submyocardium is going to be, and this is going to first start getting infarcted. Okay, but when we deal with an ST segment elevation, STEMI, what's going to happen is it's referred to as an intramural myocardial infarction, which means that this obstruction is so severe that we have now infarcted all 3 layers, and this is referred to as what is known as an intramural infarction. Okay, and again, unfortunately, most myocardial infarctions are going to be intramural infarctions. Okay. Now the way you differentiate between a non-sterile, and again, because this is important, because the management is going to differentiate if the patient has an ST segment elevation myocardial infarction or non-ST segment elevation myocardial infarction. Of course, and the way to differentiate that is with an EKG. Okay, EKG normally will show in a non-ST segment elevation. Again, we'll discuss the reasons why this happens when we deal with how EKGs work and the different arrhythmias. But these patients are going to have ST segment depression. Okay. After the QRS, normally we're going to have ST segment elevation. This is normally a QRS. This is normally the ST wave. The patients are going to have depression of the ST segment. Okay, while patients with the let's say intramural infarct, they're going to have ST segment elevation. Okay, and that's important to know over here. Okay, so that is really how we differentiate between a intramural and only a submyocardial infarction. Okay, the question is how now you differentiate between unstable angina and myocardial infarction. Okay, and unstable angina also you're going to have ischemia to all 3 of the layers, but the difference is between these 2, it's either going to be no infarction. Okay, it's unstable angina, which is really referring to that there's going to be 0 infarction. That's the most important thing you have to understand. How do you differentiate it? Well, it's actually very hard to, because the EKG also is going to show ST segment depression, just like what we normally would see within a non-ST segment elevation myocardial infarction. In addition, you also have what is known as peak T waves, okay, which is also seen in a non-ST segment elevation myocardial infarction, and it's also seen in an ST segment elevation myocardial infarction. So really, unstable angina and only a submyocardial infarction, they're really very hard to differentiate, especially with an EKG. The only way really to differentiate them is that is going to be with the cardiac biomarkers. Okay, you see normally because in unstable angina, like we said, there is no infarction. So normally only you're going to see biomarkers when only once the heart cells are going to start dying. When they start infarcted, then they're going to release all their garbage into the bloodstream. Okay. And normally there are 2 cardiac biomarkers you need to know. The first one is the CKMBs. CKMBs are the creatinine kinase. Basically, what happens is this typically rises about 4 to 6 hours after the onset of chest pain. Okay, they peak from till about 12 to 24 hours, and they go down in about 72 hours. Okay. Now, obviously, only if we're going to have infarcted tissue are we going to release CKMBs. Okay. So technically, in the acute setting, we're unable to basically tell the difference between unstable angina and a myocardial infarction. Okay. The second one is going to be troponins, specifically troponin I and T. Okay. And basically, troponins usually only start to go up within 1 day. One day, and typically go down in about 2 weeks after. Okay. So again, a lot confuse you with these 2 values, so make sure not to be confused. Okay. And really, the important point about this is really that the reason why we call it acute coronary syndrome is because in the acute setting we're unable to differentiate between a non-ST segment elevation, myocardial infarction, and unstable angina. Therefore, we basically treat them together. Okay, that's the exact point I wanted to tell you here. An unstable angina and a non-ST segment elevation myocardial infarction is going to be treating the same way. Okay, how are we going to treat these patients? Remember, they're all treated the same way, and also ST segment elevation is basically treated the same way, except for one thing. Okay, obviously we're going to be giving these patients oxygen, we're going to be giving these patients morphine, obviously we're going to be continuing the nitrates if it's appropriate to give them the nitrates. In addition, we could also give these people aspirin. Aspirin is extremely important because aspirin decreases the mortality. You see, what happens is because most of the times what happens in a complicated plaque is that usually a thrombi is formed. So because aspirin is a blood thinner, prevents blood from clotting, if we give aspirin to patients who have angina, who has potentially unstable angina, then we could prevent further obstruction into the vessel, and of course we could decrease the mortality within these patients. Now, in situations where we cannot use aspirin, in situations where it's contraindicated, let's say they have an allergy, then we're going to be giving these patients clopidogrel, okay? In addition, we also want to give these papers beta blockers. Beta blockers also decrease mortality. Why do beta blockers decrease mortality? Really for two reasons. Number one, beta blockers, of course, basically go and they decrease cardiac work, which basically decrease the amount of oxygen our cardiac muscle needs, which means that we don't have to really supply so much to properly perfuse it. In addition, the second thing beta blockers do is, again, we're going to discuss in a second, the most common cause of death in patients with myocardial infarctions is going to be some type of arrhythmia. And of course, beta blockers prevent arrhythmias from happening, okay? So beta blockers also decrease mortality. In addition, we want to give these people statins. Okay, why are we giving these people statins? Because like we said before, statins, besides for lowering the LDL and all the other stuff, basically goes and reduces inflammation within the clot. So statins also go and decrease mortality. Okay? Remember, you have to understand everything that decreases mortality that we're going to ask on the boards. Okay? All three of these decrease mortality. Okay? And the last thing we're going to give these patients is we're going to give these patients heparin. Okay? Now, heparin is actually only given to patients in situations where there's unstable angina or a non-ST segment elevation myocardial infarction. In situations where a person, for example, has an ST segment elevation myocardial infarction, we're not going to give heparin to these patients. Rather, we're going to be giving them some type of thrombolytics, okay, typically TPA over here, okay? And what's very important over here is because, remember, heparin does not actually dissolve clots. Okay, if a person has an ST segment elevation myocardial infarction, he's usually going to have a significant clot that's already formed, that's already obstructing his coronary artery. Okay, so in order for us to basically go and really fix this patient, we have to give him some type of drug that could go and dissolve the clot. Okay, heparin doesn't dissolve clots. We need TPA to dissolve the clots. Okay, now in situations, also very important over here. You only give TPA if the patient is going to have, from the onset of chest pain, 12 hours from the onset of chest pain. Let's say a person has chest pain for, since yesterday, and it's signs and symptoms of some type of ischemia and angina. Then what's going to happen is you're not going to be giving the TPA because remember, like we discussed in hematology, after 12 hours, the clot automatically has the F12 basically stabilizing it. Okay? And because of this, the thrombolytics will not be able to go and dissolve the clot. So after 12 hours, then you can go and, until 12 hours, then you can go and you give the TPAs, okay? Now, in situations where thrombolytics is going to be contraindicated, let's say the patient had a very severe, GI bleed, or let's say he had neurosurgery, or whatever reason is, in that situation, then you're going to take him for the emergency angioplasty, okay? Okay, and that is going to be the treatment for the of course, the ST segment for the myocardial infarctions. In addition, this is going to be the choice where you're going to go straight to surgery in situations where, let's say, even in stable angina and non-ST segment myocardial infarctions, when, for example, all these are not going to be working. If you try going and you give all these drugs and still it's not going to be working, then you're going to be going straight to the angioplasty. Okay? And that is basically how you manage a patient with a myocardial infarction in the acute setting. Okay? Now, just because, let's say, we finish managing a patient in the acute setting, that doesn't mean he's out of the dark yet. Unfortunately, there are a lot of other complications, specifically the most commonly in the first week after myocardial infarction, where the patient, unfortunately, could have and develop very severe complications, and a lot of time this even kills the patient. Okay, in order to understand this, we have to understand the different histology and the morphology changes what's happening basically in our heart as a result of this myocardial infarction. Okay. So the first we're going to look at the histology changes. Histology changes, first we're going to be looking at with only ischemia, okay? Now this, remember, only ischemia is anywhere from 0 to 30 minutes, well, really to 25 minutes. but we're going to say 30 over here. Okay, so as long as, let's say, 20-25 minutes did not pass yet, no cells actually died. Right? Because no cells actually died, we're not going to have an infarction. This will probably be unstable angina. Okay, now what happens over here is, well, let's look at a normal cell first. A normal cell, normally, their mitochondria obviously is pretty normal size. Their myofibrils are going to be intact, and as well as they still have their glycogen granules stored within them. Okay. However, once the cell starts getting ischemic, what's going to happen is that, number one, these cells are going to get very hungry. Therefore, all of these glycogen storages are going to be depleted. We're going to be eating all the glycogen storage, utilizing it for ATP, of course, so we can supply energy to these myofibrils. However, as ischemia continues, the myofibrils eventually are not going to be supplied properly. Therefore, they're going to start detaching from each other. Okay, and I guess we'll discuss why this is extremely important in a second. In addition, to compensate, to try increasing and revving up the amount of energy we're making in the cell, also our mitochondria is going to start to swell in these situations. Okay, and that is going to be the histology changes over here. Now, the reason why I wrote it's very important over here to understand that the myofibrils are basically going and they're going to separate, because one of the most common causes for death post-MI is going to be some type of cardiac failure. For example, if the cardiac muscles cannot contract well, we're not going to have a normal stroke volume, and because we don't have a normal stroke volume, we're going to be having a low blood pressure. And low pressure means we're eventually going to develop shock, we're going to have hyperperfusion of the tissues, and of course the patient is going to die. Okay, and this obviously is going to make the ischemia much worse. Okay, so this is one of the important reasons. Okay, this doesn't really happen in ischemia, but it's really happening over here in an infarction, where we get the severe hypotension and the shock and the symptoms associated with that. Okay, now if there's ischemia, remember, if we do not treat them, if we cannot help them by resting in nitrates, then unfortunately this can go to and lead to an infarction. And an infarction, again, like we said, is typically over 30 minutes. Again, depending on the different patient, it might be a little different, but let's just say 30 minutes. And okay, what's happening is, again, myofibrils are already separated. There is no glycogen storage granules over here. At this point, the mitochondria are already basically swelled up. But very, very, very important, the most important thing that I have to understand here is that because the cell basically doesn't have enough energy, then it cannot maintain the sodium potassium ATPases. The cell starts to get damages within their membrane, and this is the most important part. When damages in the cell have to the membrane, of course ketones and different things can now leak into the cell. Okay, and when, let's say, sodium calcium now leaks into the cell, this is going to take the cell from a resting memory potential all the way to a depolarization. Okay, and when the cell's going to keep on depolarizing, this eventually is going to lead to the cardiac arrhythmias, the fibrillations, the ventricular tachycardias, and eventually these patients are going to, of course, if it's not treated properly, these patients are going to die. Now, I'm stressing this because this is the most important reason why patients die with a myocardial infarction, because of these ketones now leak into these infarcted and very ischemic cardiac cells, and of course that leads to the electrical imbalances within the cell. Okay, so that is very, very, very important. Okay, now regarding the morphology changes, this is also important. Morphology changes really only start occurring once after, I would say, the first really change occurs from about 18 to 24 hours. What happens over here is that we get a very yellow, well, we have coagulative necrosis in the beginning, but as this continues, of course, blood is going to be filling into this area, and this is going to cause this area to become very, very vague and pale in color. Okay, as this progresses, of course, this is about from 1 to 3 days. What happens is that neutrophils start to infiltrate this area. They go and they make this place a little yellow over here. About from 1 to then about from 3 to about 7 days, 3 to 1 week. What happens is, and this is the most important stage over here, is that now the macrophages start to go and invade. And when macrophages start to go and invade, like we said, they're of course going to clean up all the dead tissue. They're going to get all the infarcted tissue out, and they're really going to start laying the pay for the fibroblasts to go and start, repairing this cardiac structure over here. But what's very important is when macrophages in the area, because macrophages, like we said, are immune cells, they're going to release a ton of destructive enzymes. And these destructive enzymes can go and it can severely, severely, severely damage our myocardial cells and our myocardial walls, okay? And when this happens, and this is very, very important, these patients are at risk for what is known as the cardiac rupture, okay? And this is extremely, extremely important because these are a very, very big complication post-MI, okay? Now, technically, there are 3 different types of cardiac ruptures, okay? You could have what is known as a wall rupture, you could have what is known as a septum rupture, and you could have a valve rupture. Okay, what happens is in a wall rupture, of course, because let's say for example our myocardial became weak over here. So let's say this is a myocardium, this is going to be a pericardium, this is an endocardium. Because our myocardium is going to be very weak over here, what's going to happen is that, let's say, God forbid, if the pressure in the heart really increases, this could go and it could lead to a rupture of the wall. Because remember, like we said, all these inflammatory markers are releasing over here, and of course that could damage the wall. And then when the wall is damaged, the blood can now leak into the cardiac sac. When it leaks into the cardiac sac, this can go and lead to a very, very, very severe pericardial effusion. Okay, even can lead to what is known as the cardiac tamponade. Okay, cardiac tamponade, like we can discuss later, is going to be extremely, extremely fatal to these patients. In addition, because a lot of blood gets into this area, this can damage the pericardial sac, and patients can have pericarditis. Okay, that's also important to know over here. Besides, for some reason we don't understand over here, patients could develop pericarditis also because usually about 1 to 2 weeks after the myocardial infarction, certain antibodies are released, and those antibodies look and seem very similar to the pericardial antibodies, and basically they go and they stimulate the pericardium, and this could also lead to a pericarditis. So there's really two reasons why patients can develop pericarditis. Number one, because in the injured, the blood is really damaging the pericardium, especially remember because if there's blood, there's going to be macrophages, and they're going to get into them, it can cause very severe damage. And in addition, what happens is, for some reason, antibodies are released into the blood, which can go and damage the pericardium. Okay, so that is the complications due to a wall rupture. Okay, now regarding a septal rupture, what happens in a septal rupture, of course we know, like we said in the beginning, the septum basically separates the atriums from the right from the left side. If we have a rupture, what's going to happen is we're going to have a shunt. All the blood from the left side, because the pressure is normally higher, is going to shunt to the left side. Okay, and of course we discussed the complications of that before. Okay, in addition, so again, this is going to be a left to right shunt. Okay. And what happens with a valve rupture is, normally with a valve rupture, again, this we also said before, what happens is typically it's going to be the mitral valve rupture. And when the mitral valve rupture, actually really when the papillary muscles rupture, they're not able to support the mitral valve, and the mitral valve is going to have a severe, severe, severe mitral regurgitation, which could be very fatal to the patient, basically to very severe pulmonary edema, and eventually congestive heart failure within these patients. So this is extremely, extremely important to understand that during the first week especially, the risk for cardiac rupture post-MI is extremely high in these patients. In addition, there's another complication associated within the first week, and that is referred to as cardiac expansion. Okay? In cardiac expansion, what happens is because, like we said, there's damage to the wall. What happens is when there's damage to the wall, again, like we said, sometimes this damage could go and actually lead to a rupture, but if it doesn't lead to a rupture and the wall is really damaged, because the pressure is very high within the ventricles, what's going to happen is that if there's a weak spot within the wall, then it's going to start bulging, okay? And when it bulges, of course, like we said before, anytime you have a circle bulging, this will go and lead to stasis around the cardiac, of course, system. And when you have stasis, this leads to some type of thrombi formation, eventually emboli, and of course, during systole, it could go and could be ejected and causing, let's say, a stroke. It could cause, let's say, renal failure, and it can basically infarct different types of systemic tissue. Okay, so that's also important to understand that this could be cardiac expansion. In addition, cardiac expansion, what happens is, eventually in a chronic, after, let's say, 6 months or whatever it is, when fibrosis starts to form around the heart. So what happens over here is now we have, again, like we're going to discuss in a second, because we have fibrosis basically can lead to what is known as the re-entry phenomenon, like we discussed in the arrhythmia lecture, and of course that could lead to very, very severe ventricular fibrillations and ventricular tachycardias. Okay, so that's also important to understand about cardiac expansion. Okay, now next, from about 1 week to about 1 month, basically what happens is that the macrophages now clear up the whole entire area, and now the fibroblast basically goed, and it's going to start laying down all its collagen and etc. In addition, note over here we also have the new neovascularization over here, which basically is going to go and start supplying this tissue over here. Okay. Oh, also I forgot to mention a very important point over here. Normally, actually over here. Like we mentioned before, what happens is a lot of times, even if we fix the problem, even if we fix the myocardial infarction and we really start perfusing the heart again, because these cells are going to be injured and we're right away perfusing the heart extremely a lot now, what's going to happen is if there's going to be a lot of blood now, that means there's going to be a lot of catechols delivered to the blood, and because these cells are somewhat damaged, we're going to overrun them with catechols, and even if we actually go and we prevent this clot from forming and we really sort of relieve the clot within the coronary artery, but because of a lot of blood and catechols coming, even after we treat them, they can develop very dangerous arrhythmias, and of course, electrical disturbances within the heart. Okay, so keep that in mind also with the complications over here. Okay, and the fifth thing, what's happening, of course, again, this is really 1 to 6 months, and what happens over here is basically, again, we're eventually going to go and lead to the fibrosis and of course scarring up of that myocardial area, wherever was infarcted. And of course, this is also extremely important because, like we said before, anytime you have fibrosis, any scar tissue basically leads to some type of arrhythmia. And of course, arrhythmia can go and be very fatal to the patient's heart. Okay, so those are the things you have to be looking out for, especially during the first week of myocardial infarction. Okay, now let's say Mrs. Johnson, let's say, survived the myocardial infarction. Okay, it's post 1 week and it's time to go, and it's time to let this patient go. Are we going to let this patient go right away? And the answer is no. They first have to do a stress test. Okay, and the stress test basically, like we said before, normal stress test is about 85% predicted. Over here, it's not going to be 85. We're going to have, and we want it really to reach 75% of the max heart rate. Okay, if they could reach 75 for the max heart rate, good. You send them home with the aspirin, send them with the beta blockers, the statins, and of course you could add in regarding this the ACE inhibitors. Okay, that's really how you're going to send these patients home. In addition, of course, also stop the risk factors. Make sure they're on a good diet, a healthy diet, and of course make sure they have normal exercise. Okay. If let's say now they have a positive stress test, then of course you're going to be going on to the angioplasty. Remember, angioplasty, like we said before, to really have the best outcome for angioplasty, you could give either clopidogrel or you could give the glycoprotein 2A, 3B inhibitors. Of course, that really helps with the angioplasty. And of course, like we said before, if it's a 2-vessel disease, less than a 3-vessel disease, or the patient does not have the LED basically being obstructed, then of course you could do an angioplasty plus a stent. If, however, you can't do that, then of course you got to do the bypass surgery. Okay, and that is really how you manage a patient with a myocardial infarction. Okay, now there's one more point that's very important over here. And although we don't have enough room, we'll just squish it over here. There is another type of angina and myocardial infarction you need to know about, and this is referred to as Prinz-Meadows angina. Okay, in Prinz-Meadows angina, this is actually very unique. What happens is these patients are getting ischemia not because of some type of atherosclerotic plaque, but because normally what happens is our coronary arteries, God designed them because normally everything in our body usually has either beta receptors, alpha receptors. It can have a lot of beta, a lot of alpha. However, the heart and, for example, let's say the brain, especially maybe the coronary arteries and the central nervous system's blood supply, because we don't want it to be affected through sympathetic nervous system and parasympathetic nervous system. We don't want to decrease the blood supply to the brain. Let's say when our sympathetic nervous system is being active. Then, of course, because of that, we do not have, or at least we have very equal amount of both alpha and beta receptors, okay? And the same thing is with coronary arteries. Coronary arteries usually have equal alpha and beta receptors, okay? Has equal of them. However, in patients with Prinz-Meadows, they have much more alpha receptors than the beta receptors, okay? This is typically seen in women, and it's usually at the night when these patients get these symptoms, okay? And what happens is, for whatever reason, we don't know what causes it, but what happens is when epinephrine basically stimulates this can go and it can lead to very severe obstruction, very severe spasm of the coronary arteries. Okay, and what's important to know over here is because when we spasm, we're going to have decreased oxygen supply, which means we're going to lead to very severe ischemia. Now I have to tell you over here that Prinz-Meadows angina actually presents as ST segment elevation. You could see it as we're looking as a regular ST segment elevation myocardial infarction. Okay. However, very important. If you give these patients beta blockers, you are going to kill them. Okay. So you do not want to give these patients beta blockers. And why? Because like we said, normally there's an equal amount of beta and alpha receptors on the coronary arteries. In these patients, what happens is there's more alpha receptors, okay? Now, because there's more alpha receptors, when epinephrine, let's say, binds to them, so the overall net we're going to be getting is we're going to be getting the coronary artery constriction. Now, the only thing keeping the coronary artery a little dilated is the fact that we have a little SIM and we have a little beta receptors being activated. However, if we give beta blockers, we're blocking all that tiny little dilation we have from the coronary arteries. And of course, when that happens, then you're going to have full occlusion of the coronary arteries, and you're going to get no blood into the cardiac cells, and therefore the patients are going to die right away. So you do not want to give beta blockers, okay? In addition, the way you treat these patients is going to be of giving nitrates, and you're going to be giving them calcium channel blockers, okay? Calcium channel blockers will prevent the constriction, and of course will open up the coronary arteries to go and supply and perfuse blood into the heart tissue, okay? The second thing you have to understand, oh, by the way, there's a test you could do also. By the way, the test you could go with angiography. This is really how you diagnose it. You can do angiography, and you can see that there's no atherosclerosis in presence of ischemia, okay? In addition, remember we spoke about the asthma patients. What happens is if you're not really sure about the asthma patients, if he has asthma, we do what is known as the methacholine challenge test to go and see. Normal people usually won't have bronchoconstriction, but however, patients with asthma will have bronchoconstriction. The same thing is really with the Prinzmetal angina. What happens is we give something known as ergovine, which basically in a normal person will not cause any problems. However, in patients with Prinzmetal angina, this basically will stimulate coronary artery spasm. The second thing you have to understand over here, and really have no room over here, and that's going to be what is known as a silent MI. Okay, a silent MI typically happens in a diabetic patient, usually some type of a diabetic neuropathy, or it can happen in very old patients who have neuropathies. And what happens is because they have neuropathies, they do not have this pain. And when they don't have this pain, they're not going to have the chest pain. We're not going to know they're having an infarction. Some patients, if they have an extremely sympathetic nervous system activation, then abnormally you'll be called to a diabetic house with very severe, for you don't know why, he'll have tachycardia, he'll have tachypnea, he'll have very severe diaphoresis, but he will not have the typical chest pains and really the symptoms we see in patients with myocardial infarction. So that's really what you have to know over here. Okay. Now, before we finish this lecture, there are two very important questions that patients, especially ask the doctor post-MI. The first thing you want to know about is, regarding sex. Can they have any type of sexual intercourse after a myocardial infarction? And the answer is if they go and they pass the stress test, then they're able to have any type of sexual intercourse, okay? Another thing that's important to understand is that a lot of men unfortunately complain of some type of erectile dysfunction after. You should know that it has nothing to do with any of the drugs they're taking. It's usually going to be psychogenic. Reassure them and let them get more confident, and it usually will go and get back to normal. Remember, a lot of patients also, regarding the treatment, we said you give the patients nitrates. If the patient is going to be on Viagra, obviously, you don't want to give them nitrates, of course, and you just, let them just take their Viagra, okay? And that is really how we manage and really how we deal with a patient with angina, ischemic heart disease, and the myocardial infarctions.